well, and this is a series of conversations and presentations I've been working up around patient access to online records, because it has been a very topical and it's a topic that's caused lots of debate, shall we say. And what I'm going to try and do here is to give a bit of an overview as to where we are and the kind of process that practices should be gearing up for. And then I'm going to aim to have a discussion towards the end as well. I'm going to try and leave quite a bit of time for that, because I think that's where a lot of the concerns will probably be raised. And if there are any specific comments, questions that you've got, pop them in the chat. I'll try and answer them as we go along. And if there are any other points, happy to take them at the end, and feel free to raise hands and come on to the mic and ask a question, or pop it into the chat. We'll try and keep this as flexible as we can. So that's the introduction, and this is being recorded to be shared more widely later on as well. So I think the first thing to just to go back to and have a look and reflect on is, where are we currently? And if we look at this journey's been going for a couple of years, if you look back far enough, but essentially this year, April, is when NHS England asked EMIS and TPP to allow practices to opt in early. And we looked at some data, and the current data we've got is that in August, 13% had opted to go in early. And where we are now is that I'm waiting for confirmation, but I'm hearing that up to 50% of practices have opted to go in early, early being before the 1st of November. Of those that have opted to go in early, there's been a lot of debate as to what needs to happen. And if I go back to review what practices have done when they've gone early, is that they've looked at the coding of 104 and 106, which I'm going to talk about, and also EMIS manager settings, which I'm going to be focusing on. And this is all working towards a go live date of the 1st of November for prospective access to be ready for switch on, really. And there is talk actually of unofficially that this may extend to the end of the calendar year, but that's yet to be confirmed. So I think the biggest debate has been the contractual obligation. And again, some of you may be aware from previous webinars that the contractual wording has changed over time. And I've kept the link in here so that people can refer to it in future. And what I've done, just put it on mute, there we go. What I've aimed to do is to just pick out some of the relevant sections from the contract here. And I think effectively it's gearing up to the fact that patients should have access to prospective access, and where it's not provided, then the patients practices should be working up to provide it. But I think the main point I'd like to just highlight is point 7, which is at the bottom, where if for whatever reason the contractor has not before the 1st of November provided the patient with a facility, then if the patient makes a request after the 31st of October, then that provision should be provided. So that's part of the contractual requirement that I've reviewed, and with colleagues come up with a series of options. So that's the contractual obligation. So where are we now in terms of what wider space? Well, the early release of records, or early access to prospective records, isn't strictly speaking contractual, because there is some flexibility in the contractual wording on there. And the focus from NHS England is that patients also aren't blanketly coded, so practices aren't blanketly coding 104. So that's essentially a position to look at. And I think if you look at what NHS England have been doing, is that they have been promoting this in various forms. And some of you might have seen a couple of weeks ago that NHS England stated that this had reduced the administration burden. But if you look at the last line there, the BMA GP committee still had concerns about the rollout. And whenever I see these kind of articles from NHS England, I always want to get a feeling of what practices think. And often, if you read Pulse, if you go to the bottom, you can see the comments, and I think the comments kind of give a completely different type of view around what the thinking is around online access as well. So there is certainly a wide view as to does it work, or what are the benefits overall. And I think if we look at what the BMA have said, the BMA are actually going to be bringing out some further guidance this week, is what they said. So we're just waiting on that. But the last update was around this, and what they said, and this was last month, with the update, that there was still some patient safety and IG concerns that are outstanding and need to be addressed for it to be successful, and appropriate time and resources needs to be required, and they would be focused on reassuring practices that they have time to consider matters. And I think this is where you've got different positions going on, and some of you might have seen the email sent across from NHS England through EMIS and TPP, but mainly via EMIS, where there's a go live confirmation that NHSE would like all practices to click and sign and get approval to switch on prospective access. But I think from my perspective, it's very much ensuring, if you're checking these boxes, that you've got confirmation that you've done the readiness checklist and you've gone through the EMIS guidance. And if you look at the readiness checklist, it is quite detailed. So it's looking at making sure that you've got the processes and policies in place at your practice. Your staff should be fully trained. There's some other webinars that NHS England have put together. There's a clinical safety report that's available that highlights some of the early learning from the programme. Staff should be aware what patients will see in the records, and looking at redaction, and that it should be promoted and offered. So there's quite a lot that practices have got to do, and no doubt there are lots of other competing pressures at the time as well. And if we look at the actual clinical safety report as well, here we go. So if we have a look at the clinical safety report, I think it's probably worth reviewing, because this is something that was published a year ago, and in it there's a lot of detail as to the issues that rolling this out may provide to practices in terms of mitigation that practices need to be looking at, and most of it is around good training practices that practices should have in place, really. So there's lots of detail in there, and I'll keep the link in there. The other point that they've put in is the ability to redact. Now, the only redaction facility that practices have got is in the on the clinical system, and again, I'd encourage all practices to go through this process where they know how to redact information from online visibility. So the common confusion here is that we've now got two buttons. We've got a confidentiality button and an online visibility button. It is the online visibility that stops the whatever entry you're putting in to be viewable by patients. Confidentiality is a separate thing that looks at access to other staff, for example. So online visibility is what we should be looking at within the consultation, and also the same thing in the care history. You can mark things as not to be visible in the patient's online record, medications as well, and documents. Then there's a whole list of information that I would encourage practices to know about, because this part forms part of the preparation that practices should be aware of. And in a way, this is a feature that has been brought up gradually over time, and we're looking to try to embed the learning into our practice. I'll come back to answer some questions just when I've run through this bit. Thank you. So one of the other aspects of this is very much around the concern that a lot of practices have is who actually has access, and there are several groups of patients that you might feel actually shouldn't be getting automatic access to their records. So there may well be patients you would want to identify, and part of the problem is that not all these patients are coded. So what we can do is to run proactive searches to exclude patients, because there is no specific redaction software per se. And this does also raise the question about who is actually the data controller. Is it the actual practice, or are NHS England now becoming the data controller by effectively imposing the contract on practices? And there's been lots of changes of goalposts along the time, and one of them is around GP to GP, because historically what's been an issue is that you can mark your patients as redacted for their record. So you can mark confidential information or not visible for online access for your patients in certain consultations. But when that patient moves practice, all of those hidden things get opened up and don't get transferred along the medical record. So that's been a ongoing issue, but it necessarily doesn't affect prospective access. It's more a retrospective access issue, but it's still a significant concern. Although there has been a recent update that there will be a new solution to allow the restrictions to travel with the GP to GP process, but we're looking to see when that will actually arrive. So there are several messages we're hearing. So NHS England really want us to look at the global settings and to resolve any bulk codes, and they've brought out lots of guidance alongside that. And the practice concerns are valid, and access may not be to the patient who the record is about, because there's lots of, for example, safeguarding concerns and domestic violence types of issues that we need to be aware of locally. Often we're not sure about the email addresses, mobile numbers. Is it the relative? Is it another proxy that's got the access? Not all patients are coded and therefore won't be picked up in a search. And then there are issues with staff turnover and the use of locums, because the assumption is that practices have got to keep those staff trained. And the codes are available. So the 104 code is available for us to apply to patients who we feel, if we are processing the record to be bulk uploaded, then we can apply a code to prevent certain records being bulk uploaded for online access. So that's something just to be aware of. And there are a whole load of other codes that have been offered as well by NHSE as well. So there's lots of different codes we can do. And one of the things that we've looked at locally is actually, can we provide some support for practices around preparation for what they can do? Because effectively, I think there are three options for practices. They can either they've probably already gone live already, or they're considering going live, in which case they need to run some searches to assure themselves as to where they are. Or the third option is not to go live and to enable the records upon patient request from the 1st of November. So they're the three kind of options that we've got. And if we look at these support searches that have been put together, this is mainly to help. And I'd encourage practices to download this, and we'll circulate the link to review these. And we've had some feedback, and we've looked to try to improve on these searches over time. But essentially, if there's any patient who doesn't have a prospective access code, you may want to consider. And what some practices are doing is that they're basically, if they're not sure about the record, they're coding them with a 104 until they are sure about the patient, and are happy that there's nothing of concern to allow that patient to have access. And then those patients who may already have online access but have been given a 104 code, you may just want them to have a 106 code to override the 104 code, because if they've already got online access, some review has possibly already taken place. During the pilot phase of this, there was a whole set of searches that were put together, which was from adopter sites who looked at those who may lack capacity and they put together some codes for this. And practices again might want to look at those who don't have online access and don't have a code applied, and whether those patients do actually need to have a code applied. One of the other things that we've done, and one of our facilitators in Citizen Hackney has put together some protocols that will also flag in the notes if a patient comes in and they've got a significant code such as safeguarding or lack of capacity, and we're looking to try to get that rolled out to all practices as well, just for information while you're consulting on a day-to-day. The other search here is those who have got online access who lack capacity, and whether if they've already got online access, whether you want to apply a 106 code to them. So again, there's a series of searches here that practices may want to look at. So the kind of process that we could ask practices to do is to make sure that you've got your EMIS manager set up. Now, the default that NHS England have suggested is you set it to the 1st of January 1900 as a one-off process. And this has been quite contentious because this is very much for retrospective and not prospective access, and has caused quite a bit of concern for a few practices. And it's not contractual as to where you set this. It's just advisory as far as I can see. And what we're saying to practices is do what you feel comfortable with doing in terms of setting this. I think the focus is to set it to this date, but some practices have set it to another date that's suitable for them. The other thing that we've looked at is actually set up a Florey questionnaire. So this is a Florey question. I'm going to talk about this in a bit more detail in a bit, but this will actually support practices in getting patients to effectively be aware of what are the implications of getting online access. And rather than them filling in a form and then handing it back and you scanning it in, you send out this Florey, and then it basically will send it back and code it into the medical record directly. So we've set that up, and again, something that you can download with a link that we'll share. And then having a clear pathway to have practices to allow patients to request access, and both patients and staff understand. And one of the key things here is if we can get all of our staff to just download the NHS app themselves and have a look to see how it works, it's really powerful way of getting everyone to know what the functionality is. And we're also looking to promote the NHS app generally, and there's some comms that will be coming out in terms of posters and website banners that could be used, and then just making sure that the process is clear for everyone really. So practice is it's mainly about process, which is outlined in the RCGP guidance as well. And for patients, I think it's very much a matter of actually let's make it easy for patients to have a smooth process when they request it. So when patients request online access, then what happens is that the practice can then issue them with some information and a sign-up sheet. And what we've done is that, again, make it easy to do that through a digital means. So you're not giving the patient a form to fill in, you just send them a questionnaire link, and then this will ask them several questions about their access to the record, and just some confirmation that they're agreeing to some statements which practices can be assured by. And if they go through that will then come to the practice, and then the practice can have some assurance that there's some agreement in place as data controllers with the patient that you're releasing the records to. And then if the patient completes that gets saved into the notes, and it's a practice's own process whether further identity requirements are needed. Some patients you may want to get them to come in and confirm who they are, and other patients you may be quite happy to approve. So having some process there, and then essentially some kind of code that you've had this patient apply and has requested access. And then at that point, there's several things that can happen. Either you can give full prospective access and prospective access at that point of verification, or you can give patients some information that their request will be processed within a set period of time, such as 2 weeks. And this is mainly for patients who you feel actually we can give them more than just prospective access. We can give retrospective access as well. And again, it's not retrospective access is not contractual, but it's if patients are requesting access, by and large, they're looking at what's in the history rather than what may be in the future. So that's again something that practices should look at. And certainly what a lot of practices have taken this opportunity to do is to review the records within that set time period, and then do things such as, tidy up the problem list, the medications, mark anything that might be confidential as such, and then roll the process out to the patient from there. So that's the kind of process if you're doing things on a individual level where patients are requesting access. And I think the other options would be if you're looking to opt in prior to the 1st of November, then making sure that you've got the right processes in place and you've run the searches that are required to review your patients. So I think the take-home points certainly from this is to download those searches and review the codes and what are you coding within your practice. Have a look at the Rory questionnaire, because that will help support patients who walk into your practice and ask for access or ask for retrospective access, and then make sure you've got some practice and patient processes implemented, such as those that I've discussed, and also look at what other practices are doing and maybe see if we can get some consistency going, because I think certainly from my end it's very much allowing practices to be comfortable that if they are allowing global access to all of their patients having prospective access, then practices understand the risks that are associated with that and the mitigations they need to take. And if they're not going to opt in, that they've got a process in place so that if patients are requesting, that there's a process in place that they can meet the contractual obligations for. And either way, just to ensure that you've coded appropriately for those patients if in the future any bulk uploading is done, you've got some protection as data controllers within your practice. So they were the main points I was going to make. I'll come off the slideshow and feel free to pop on your cameras and I can take any comments and questions. I'll start off with, there's quite a few in the chat, thanks for that. So okay, just some advice that MS Teams works better on MS Edge. That's a good tip. And with a different hat on, we're trying to get you to use Microsoft Teams through the web portal rather than the app, because it's much slicker and doesn't slow down the system as much. There we go. Oh, I hope you could hear me. The volume was quite low, so did that. Hopefully I don't need to repeat too much. So we cannot possibly find all patients who should not have automatic access. Really good point, Aisha. So I think that's one of the issues around if you're concerned about your patient cohort not having the access, having been coded and being automatically given access, then look at the option of to just providing access upon request, and that way you've got a bit more control over the process. A comment, no GP practice member, clinician or not, should write anything in the patient's notes with control of untruthful, pejorative and libelous comments from other agencies that enter the comments into the record. Exactly, and I think this is one of the biggest concerns, which kind of was placed through some of the other comments that have come through over the last few months, and that's very much around who is putting the notes in, because this prospective access is everything. So it's not just our record, but it's the documents that we're putting into the patient's notes. It's all the free text that's going in as well. So stuff that's coming through from secondary care, for example, or from third parties that goes into the notes, patients will be able to see, and undoubtedly that they'll come to the GP practice to query it. And what you're bracing for, Shahid, is I think similar to what the feeling is elsewhere. Brace yourself for wrong documents on patient's record. Yeah, so I think that's very much one of the reasons why some practices haven't gone to put their EMS manager to the 1st of January 1900 is because of that reason, because they historically have got lots of records, or they're a practice where they've had lots of new patients constantly joining. The turnover is really high with patients. You can't really keep up to date contemporaneously, so therefore they've set it differently, and again that should be practice discretion to do that. A report who's responsible for those that slip through the net of the codes, and I think that's right, because I think actually the codes are only as good as the codes, and anything that isn't coded doesn't get picked up, and I think that's where a lot of the concern lies, and which makes which makes us all think about actually what is the best process that we can do. Do we recommend sending the flow to all patients on the practice list? No, it would be a quick answer, because I think this is very much designed to be a process that you send upon patient's request, not as a general blanket send out. Last, we've started sending the questionnaire of Accurx as a pilot to 3 to 50 patients as a tester. And you've added another question about proxy. Absolutely. And I think one of the things about the questionnaire is that when you download it, it goes into your Accurx Florey section, and then you can personalize it. So if you've got something you want to tweak, absolutely fine, and that's really good. The slides will circulate through the training hub, and the Florey, the link will be there as well. We'll put the link onto the chat at some point as well. For practices that are bulk activating, are there universal protocols we can adapt for our practice rather than writing them from scratch? So the RCGP in the toolkit have provided quite a lot of templates that can be looked at. A lot of these, I suppose realistically, we all probably have them. They will probably just need to be updated in a way, and the RCGP do provide templates for those. I think the main focus for me is that whatever protocol we've got in place, our staff know about it, and we make it simple for our patients and our staff to actually run through and enable when patients come in with queries. What dates are most practices using for EMAS settings? That's a very interesting question. It varies. I suppose that's a diplomatic answer. Some practices have set it to 1st of January 2020. Some have done it 1st of January 2010. Some have done it 1st of January 2000. It's what you're more comfortable with. The 1st of January 1900 is very much a recommendation, and that's based on the fact that actually, I suppose if you look at the benefits, if you've got a practice where you've got a patient population who have got online access and they're accessing retrospective data, then, for example, if they do a SARS request, you can just say, you've done a SARS request, here are your codes for online access, and they've got access to everything that they historically have got in the record. So what you set in your EMS manager is your default for the practices, for all your patients, sorry. And then you can tweak your settings for each individual patient. So it is very much your global setting. I suppose the flip side of that is a concern. So, for example, if you look at your EMS manager now and say your setting is the 1st of January 2020, and then you change to 1900, all those patients currently with access would suddenly get access to a whole load more of their records, which again may increase some burden on practices as well. If a patient's given proxy access to their children under 16, will this stop when the child reaches 16? So the thing to talk about is the contractual requirements are for adults only, it's not for children. But with proxy access, that's very much still in control of the data controller, the practice. And there is a automatic cutoff. So when the child turns 16, all access gets rescinded, and the proxy and the patient themselves gets a notification that it's been done. So that automatically stops, and then it's a practice decision whether that's re-granted as well. Class talks about we're using 1900 for all patients as it covers the oldest patient at the GP practice. So yeah, it's certainly an option that Interest England are advising. What about parents requesting access for children's records? So again, that's very much on a case-by-case basis. So the question would be, why do they want access? And if it's access for a specific reason, you can grant it for that specific reason. So if it's just the problem list, or if it's just the medication, you can limit the proxy access to just that focus. But particularly proxy access, I think we need to be quite careful about who gets the access and what level of access we grant. Has there been any comms in regards to inclusion practices, the homeless and rough sleepers? So generally speaking, the homeless practices and those who've got transitional patients, then effectively prospective access you can withhold on the basis that actually these patients are constantly moving around. They've got lots of concern that you'd probably want to discuss with them, rather than, for example, they have a blood test and the results they get themselves. You'd probably want to talk through things with them. So there might be certainly an argument for those patients to have them all marked as a 104. Shides, another concern about divorcing parents weaponizing their children's medical record. That's certainly another concern. So certainly it's outside of the scope of this particular requirement, but it is very much a concern around proxy access and access in general, where actually it doesn't have to be children, it could be other adults. So certainly an experience that's been shared has been around domestic violence, and one partner having access to the other partner's medical history, and if it's automatically granted, then that may well cause some concerns. Has asked about patient with obstructive sleep apnea in the safeguarding code to stop online access. Is the criteria for the codes used? So the only criteria is what I've shared on the searches, which is from the pilot practices, which is around capacity. If there are other codes that you want to include, then absolutely fine for you to code. But I suppose where do you stop with the coding? That's the other flip side of it. I'll go to the hand. So certainly pop your hands up, and I'll have a sip of tea while you ask your question. So Sanjoy. You're on mute. I'll come back to you, Sanjoy. Don't come off mute. Or anyone else want to pop their hand up? Otherwise, I'll go back to the chat box. Let me open that up again. Okay, so in regards to gender identity issues, can parents be given access when the child is not comfortable? So again, this is very much comes back down to competency and information governance, and I think it'll be a very brave data controller that will go against a patient's request not to give access. So I think you just need to be a little bit more cautious. So if there is any concern around, so if a patient comes and says, I don't want my record to be accessed by anyone, or I do not want access at all, then I think that needs to be coded and honoured, because otherwise you're placing yourselves into information governance risks there. For patients who have no code, do you advise we give the 104 code? So certainly, if you look at the searches, it alludes to the fact that if patients don't have a code, the question you should ask is, do they need to be coded or not? And that's very much an issue around actually how safe are you feeling as a practice. So just to bear in mind that the codes are only applicable if you decide to opt in for bulk uploading. So for example, if you as a practice decide we're not going to be bulk uploading, we are only going to offer access on a as required basis. So patients request access, then I'll grant access. Then the coding theoretically is just academic. It's not that relevant in that respect. But if you are going to be opting for bulk uploading, or now or in the future, then the coding is important in respect of those patients will then not get access if a bulk upload is is enabled. So it's very much have the bulk uploading discussion, and if you are going to be going ahead, then making sure that you've got good coding in place. If you're not going to be bulk uploading, then the coding is less of a relevance in that respect. Can the practice restrict what patients can see on their prospective access from the 1st of November? Is it all or nothing? If you're automatically enabling the record, so if you have a bulk uploading and things are automatically being enabled, then it's everything from a set date that is visible to the patient. The only way you can then restrict it is to go in individually into each record, which is why the flip side of just doing it on a per request basis becomes a bit safe for data controllers, where they've got control of which patients have got what access, and then you can set everything, or you can set a limitation based on what you know on the patient. But if you're going for bulk uploading, then if it's not a patient with a 104 code, it'll be everything that'll be visible, unless you're also marking the record as individual consultations, for example. So yeah, it's everything apart from what you've coded not to be visible. The ones that have been coded 106, will there be any changes of live online access? So this has been the debate that's been going on. The latest feedback we've got from EMIS is that if patients have got online access currently, nothing will change for them. So it doesn't matter what you've given them as a code, that's not going to change. Although the safety net that I've put into the searches is very much just code them all with 106, just so that there's that assurance there. But EMIS have said that if they've already got online access, the codes are not going to be an issue. The Florey questionnaire, we'll put down a link for the Florey questionnaire, and we'll circulate it on the slides where you can download that from. Patients in the 104 cohort, should we send them the Florey, wait for them to contact us? It's designed for patients to contact us, so it's patients will say, can I have online access, and then you send them the Florey. We're not expecting patients to be bulk sent the Florey at all. In regards to the go live date, if a patient does register via the NHS or patient access app, will we need to give the patient a linkage key post online access registration? Okay, so if I today download the NHS app and my practice hasn't enabled early access to prospective records, then I can only order my repeat prescriptions and book appointments, I think, are the two only things I can do. So I would still need a linkage key to access my medical record. From the 1st of November, if my practice has enabled online automatic access, then from the 1st of November, I will be able to see anything from that point onwards. Or if my practice hasn't enabled anything at all, and they're doing it on an as request basis, then I would not see anything apart from prescriptions and booking appointments. And then I would ask my practice for access, and the practice would provide me with a key or enable the access for me individually. So it's one of those things that will happen, but it's it's very much what level of risk safety you want your practice and your patients to be at. The patient who does not have online access now, do they still need to access by requesting a linkage key? So yeah, so basically, if they don't have access to the medical records, there would need to be some kind of governance. The current governance is they would need to request access. Somebody needs to vouch for them to say, yes, you are who you are, and then you give them a linkage key. Once our bulk upload is done, if I then change the global settings for free text access to another date, then it'll be restricted. So yes, that's correct. So once you've set your bulk upload to a certain date, if you then change that date, then essentially that's your global date. So from the date you change it, then that will be the new date that everybody will have. So if your bulk upload was done on the 1st of January 1900, people will see everything. If you then change it to the 1st of January 2023, then they will only be able to see stuff in 2023. Nobody in your practice population will be able to see anything beyond that. So the global setting applies to everyone, and then you need to update that. So when you update the global setting, it affects everybody, and then you'll have to go into each individual record to set a individual date if you're looking at retrospective access. So that's not prospective, that's retrospective. And that's also raised the query around why is that being set now? And the thinking is that, you know, once people have got prospective, they realize they can't see stuff in the past, and they'll come to the practice and they'll start saying, can I have retrospective access? And then if they get retrospective access, they'll get everything in the history as well. So again, it's what level of confidence practices are at in terms of the record, which is why I think if you go through the process and say, actually, if a patient requests access, then the practices should have a viable time to say, actually, if you want to see stuff in your record, then you need to give us 2 weeks. Some practices have said 4 weeks, and then we will review your record and then we'll give you access after that period of time. You don't have to supply access immediately. It's very much you need to have a process in your practice that you can be safe from doing. There have been a few patients complaining that their online access has stopped working the past week. Is it a separate issue? I suspect that's a separate issue. The codes are only apply to bulk uploading. So if you're not bulk uploading, the codes don't really mean much apart from you noting in the record what you've done. What about florries that are sent to 2 different patients but share a mobile number? And again, that's the issue. When you send a florrie, it is linked to that record. So if you send it to a specific mobile number and that mobile number exists in a different record, the florrie identifies that this is this patient you sent it to and not this one. So it will send it back to the right record. But again, it does raise a concern about patients having sharing numbers and email addresses. 104, 106 code, what's the difference? So 104 code, if you are uploading in advance and going for bulk uploading, 104 will stop that patient having access. 106 overrides and removes the 104 code so that patients will get access. So 104 in effect is a blocking code. 106 is an unblocking code. You can look at it as that way. And it's the 104 codes which NHS England are concerned about, because there are some practices that have put all of their patients as 104, which is an option, which means that everybody is blocked until the practice reviews the record on an individual basis. Doesn't the patient need to be verified with photo ID, as they will have access from the certain date anyway? And again, that's the concern. So is the patient who gets the access really the patient who says they are? And I think that's the concern that's been raised. So if it automatically happens that from tomorrow all my patients get access, can I be sure that the person who's looking at it is the patient? And there are some assurances that NHS-E have built into the NHS app. So to be fair, there are lots of safety features within the NHS app, but if somebody then has the password for that app, then potentially they can still access it. So I think you just need to be a little bit careful about whether that's a concern within your practice or not. Is retrospective access going to become compulsory? That's a real good question. It's an ongoing debate. So it hasn't been said it's going to become compulsory, but you know, if we go back a few years, this wasn't compulsory either. So we don't know. And you're absolutely right. Retrospective access is going to be a lot more work if that ever becomes compulsory. But it's I think this is where the BMA come in and have to fight the corner of the practices and the LMC to support and promote these kind of issues. Review of retrospective access will take up lots of clinician time. Absolutely, I think clinical time is going to be taken up, but there are things that you can do to speed things up. So looking at your practice and saying, at what level retrospectively am I comfortable with going through, and how many requests am I getting on a regular basis, and then working out actually could a senior admin could do a quick screen, and then any concerns can go to a clinician. So there's different ways you could look at doing that within your practice, but it's about what process do you have to provide yourselves with that assurance, really. If you've planned to bulk upload from the 1st of November, but decide you don't want to, they want to do it on individual patients, what's the process? So if you've signed up for bulk upload and you're saying you don't want to do that now, then I think what you probably need to do is email EMIS, because EMIS are the ones who are going to be enacting the request, and you just tell them that you've rescinded your permission and you would want them not to go ahead with it, and ask them for confirmation that they've acknowledged your email. I'll pause that. I've seen a hand. So, Amin?
Thank you, Osman. Can you hear me okay?
Yeah, I can hear you.
I had actually two questions, but as we are going through the chat, you already touched on the first question. So I'll just ask the second one. From the patient perspective, if I'm a patient and I request my access for some reason, let's say my surgery decided to apply that blanket, and despite my all repeated effort of getting access, if I still don't get it, what would be my rights? So I think as we're working for GP surgery, we also have maybe family member that we care for. What would the patient's right? Thank you.
Yeah. So you know, whatever I'm telling you now, I'm a very strong advocate of patients having access to the record. I just want them to have access in a way that the data controller has got some control with. I suppose if I'm to put down my position, that's the position I would be at. From a patient's perspective, if they've requested access, the practice should review my access and give it to me. If they don't give me access, then the practice should tell me why. And I think that's the process that should be followed. If then the practice does not adhere to that, I think that's when we run into problems. And that's why I really emphasize practices to have a process. From a patient's perspective, they can then escalate that to the ICB and raise an issue with the ICB. And I publicly said on various patient forums that I'm happy for patients to also contact me, though don't spread that, because I'd be happy to support patients to get access, because a lot of the time it's down to miscommunication or processes within the practice that cause the issue, and nothing more nefarious than that. So I'm really supportive of patients to get access, but practices should have the right as the data controller just to review to make sure that you know, I'm accessing it legitimately, and that there's nothing in the record that you know, refers to third parties or whatever. So I think that's where I would go. But the escalation for patients is very much the ICB if the practice isn't complying. Is that right, Amin?
Thank you. That was really helpful. Thank you.
Thanks. Chaya?
Can you hear me? Sorry,
Yeah.
my place of work. I just have I know it might be a silly question, but I may have missed it, the conversation as well. So there was a deadline to sign opt-in form, and on some point, if the practices hasn't signed, and the record will go live from 31st. So does that means the patient still will be able to access it? And if we haven't removed a 104 code or 106, not input the 106 code, how will that affect the practice?
Okay. So basically on the 1st of November, if you've opted in already, then patients will effectively, all your patients will go live unless they've got a 104 code. If you haven't signed the opt-in, then nothing happens. It's basically we are as you are today, where patients will then request access, but then you should have a really good process of processing that request. So that's why at the very least, That's why I emphasised in the presentation about making sure you've got a process and put together a suggested process. Make sure you've got a process, because what one of the things that NHSE and the ICB can come back to practices and say is, why do you not have a process in place if patients are requesting it? So there are some practices where patients request access and they say we can't give you access, which is probably the wrong thing, or is the wrong thing. You should be able to say yes, you can have access, or we have concerns, and these are the reasons why we're not providing access. And I think that should be a practices process. So if you, on the 1st of November, if you haven't signed up to go live with bulk uploading, then that is the status quo. That and over half of practices are in that position at the moment in North East
Thank you.
London.
Thanks. Really appreciate.
That's right, Shahid.
Yeah, thank you very much, Osman. Sorry, I probably being thick because I'm missing this. We're in the process at the moment as part of a QI project to actually get as many people signed up to the NHS app as possible.
Yep.
Correct me if I'm wrong, but the impression you gave me is that then we don't actually have to do that much, except perhaps for the stragglers who aren't signed up for the NHS app yet.
Yeah, absolutely, and I'm very much an advocate of patients signing up, and I think within our practice, we're almost 50% of patients have got access to various levels. Some patients are just medications, some have got the full record, but then what you're describing there is that you are in control. So you are encouraging patients to sign up. You're reviewing the record. You're basically doing it in a stage managed process through a QI process, which is absolutely great, and I think that's the way that we should all be aiming for. What I suppose the challenge is if half your patients suddenly get access and you don't know about them, and they're accessing stuff that you would otherwise be quite wary of them accessing. So that's the concern with the automatic access. But if you're in a process of encouraging patients to access the app and it's done in a managed way, I think that's commendable, and that's what we should be aiming for.
Right. Thank you very much, Osman.
That's right. Thanks. No hands there. I'll just go back to the Charles. Quite a few that have come through. Where did we get to? Going back to photo ID. Is it unlawful for practices to request photo ID to verify? So it's so essentially there is no requirement for ID to be requested. But if practices have concern about the identity of the patient, then they're within their rights to request it. So I think that's essentially where we stand. Photo ID should not be a barrier. If you can identify the patient comes in regularly and you know who they are, they don't necessarily have to provide photo ID. It's those that you're unsure about, or you're actually having some concerns. There's a vulnerable patient record that's going to go out. Is the person really who they say they are? That's when you may want to consider verifying the patient. What about patients with no mobile phones? We can't send the florey to them. Yep. So if that's the case, then you default. You can always send them an email with Accurex. You've got the option of mobile phone or email. You can otherwise you fall back onto just a printed option. But if people are accessing their medical record on their smartphone or their PC, they've probably got a mobile phone number or a email address. What the policy after the go live date who are newly registering with the practice. So again, the process is that we should be promoting online access to those patients. Now, when a new patient joins, so if I'm a new patient, I join your practice. If my record does not have a 104 code, I will automatically get my prospective access. So that's going to happen unless when I join, I'm given that 104 code, or the practice decides to withhold access. So there is an automatic prospective access for new patients, but then I wouldn't know unless I go onto the NHS app, for example. So that's one of the caveats in there, which is a very good point. Does the flow show who the patient is responding? So if the family have 3 children with the same surname, so essentially when you send the florey, it's linked to that record. So even if there's different mobile numbers, so the same mobile number you send it to, the Acurex florey will go to the record that you're sending it from, and not into one of the other records who've got similar details. You have 7 days to reverse the bulk upload. When uploaded it, you can't reverse after 7 days. Yeah, so that's correct. So if you do a bulk upload or any bulk coding, you've got there's a time period of 7 days where you can basically go back on that if you need to, but it's very much you need to speak to EMIS about the process if you're changing your mind. Following on from your answer about emailing EMIS to resend a request, do we then bulk add the 104 code to all patients? So again, I would download the searches and have a look to see certainly all those who have got online access. So the way that so quite a few practices have done this. They've looked at the searches. Any patient with online access they put down as 106 because you're overriding because they've already got access. Everyone else are applying with 104. So that's an approach. Some practices have said we're only going to do 104 to those at risk, and that's another approach. So I think the fact is that you just need to consider who you're going to be doing it for, and then again making a a judgment as to where you feel. But again, the thing to stress is that the codes are only relevant for you as a practice if you are going to bulk uploading. If you're not bulk uploading at all, then there isn't as much pressure to do it. Can we get a step-by-step guide? There's the step-by-step guide that I've put on. What I'll do is that I will, as we talk, I'll find it and I'll put it into the chat. There are several things that we've put on onto one of the portals. Simple guide, okay, that's fine. Actually, we'll be sharing this as well more widely. So here's one guide. So I'll put on the 2 guides which were done previously and they're still relevant today. So that's one about process, and then there's another one specifically for online access. And actually, this second link has the florey in it actually as well, and the searches. That's in the second link there. Copy of the transcript, the video. I think the transcript has been done as well on this. Third time I've put in this chat, sorry. If the date is set to the 1st of January 1900, we go live tomorrow. All patients see all of the records. Okay, so if you've set it to the 1st of January 1900 and you go live tomorrow, patients will only see prospective from tomorrow onwards. They will only see the retrospective stuff if they ask for the retrospective stuff. But if you set it to the 1st of January 1900, they will see everything going back to the 1st of January 1900, and that's where that level of where you set it will come into. So if a patient says, I want to have retrospective access, then how far back do you want to go for that? Automatically, it's only prospective, it's only going forward. So if I've never seen the doctor and I am never going to see them over the next year, I will not be able to see anything because there's nothing in my record. It's only if I ask the practice for retrospective access, and that's the other concern where patients will expect that when they hear about this and they say, "Oh yes, it's going live," they'll assume that I'll be able to see everything when actually they can only see prospective. So yeah, again, that might generate a bit more workload into the practice. EMIS have said there is no workaround if you have surpassed your 7 days. I've raised a development suggestion to their team. Okay, so that's a really good point. So thanks for raising that, class. So if 7 days surpasses and you've been enabled the bulk upload, then you have to manually change each patient. So that's a really good point. So I think, yeah, this comes back to the point of before signing that bulk upload for NHS England, you are making a informed decision, which is the assumption when you send that into EMIS. The searches are on the second link. So if you click the second link, what you'll be able to see then is this page. So this is the practice action for online access. And if you scroll down, the searches are there, and I've just gone through the searches there, and then the Florey questionnaire is linked in there as well. So it's in that second link, and we'll share that and circulate that with the minutes of the or the recording. So I'll just try to wrap up now. So just curious to know, what are the benefits for patients to have access to the record apart from having the information available? So it's always good to end on a bit of controversy, I suppose. And I suppose the question is who's driving it. So I would just say it's very much NHS England driven. And yes, you can make changes to the Florey when you download it. I'll be around. I'll take further questions. I know we've gone round, but we'll stop the recording, and I'll stay on for a few more minutes. But thank you very much for your persistence, and happy to take any further questions. Thank you all very much. We can stop the recording.